Hi everyone. Let's discuss neonatal jaundice. So, why is it so important for us to know what neonatal jaundice is about? So, jaundice in the newborn affects as many as 60 to 80% of neonates, 60% in term and 80% in preterm. Now, it's extremely important for us to be able to identify jaundice, find out the cause, and then offer treatment within the right amount of time. All of this is important because we're trying to avoid the so-called dreadful long-term neurological complication of jaundice in the newborn, which is called kernicterus. So kernicterus refers to a chronic bilirubin encephalopathy, wherein there is deposition of bilirubin in the brain, particularly affecting the basal ganglion. So it can lead to cerebral palsy, dystonia, dystonic CP basically, movement disorders, hearing deficits, and long-term neurological sequelae. So it's very important for us to be able to identify jaundice, find out the cause. So newborn jaundice can be because of conjugated or unconjugated bilirubin. The causes are different and the treatment options available are again different. That's why we need to find out the cause and then offer the right treatment within the right amount of time to prevent long-term neurological complications. So I have divided this topic into two parts. In the first part, which is this one, we're going to look at bilirubin metabolism, the pathophysiology of jaundice, and history taking in a newborn who's presenting with jaundice. Whereas in the second part, we'll stress on the clinical examination, the investigations and treatment, and discussion with viva questions. So let's take a peek into bilirubin metabolism. Now, this is the very basic of neonatal jaundice. Once this is clear, then the entire discussion of what leads to jaundice, why is jaundice so common in the newborns, and how do you identify the cause becomes extremely simple. So let's go over bilirubin metabolism first. So we all know that bilirubin is produced from hemoglobin. So when the RBCs become old, senescent, so the lifespan of RBCs in adults is 120 days. The lifespan of RBCs in newborns is less, is as low as 90 days. So once the RBCs become old, the hemoglobin breaks down into heme and globin. Now the heme undergoes oxygenation by heme oxygenase to get converted to biliverdin, and biliverdin undergoes reduction by biliverdin reductase to form bilirubin. Now, this bilirubin is the free bilirubin. This is the bilirubin that we are most worried about because it's this free bilirubin which can cross the blood-brain barrier, enter the brain, and can cause acute and chronic bilirubin encephalopathy. Okay, so that's why when we talk about unconjugated hyperbilirubinemia, which is the most common type of jaundice in newborns, it is this free bilirubin that is in the blood which tends to cause complications, and that is what it's important for us to identify this and treat it within the right time. So once you have this bilirubin produced from heme, it binds with albumin and is brought into the liver. It undergoes the process of conjugation by the enzyme called UGT1A1, which is UDP glucuronide transferase enzyme. Once the conjugation happens, the conjugated bilirubin, which is basically water soluble bilirubin, is excreted into the bile duct. As it moves down from the bile duct or from the biliary system, this conjugated bilirubin then enters the gut. Okay, so you have the conjugated bilirubin leaving the bile duct and then entering the gut. Once it enters the gut, a majority of the bilirubin gets excreted either in the urine or the stool in the form of stercobilinogen and urobilinogen respectively. However, a small portion of this conjugated bilirubin undergoes unconjugation, okay, or deconjugation, and it gets converted into unconjugated bilirubin by the help of the enzyme called beta glucuronidase. And this unconjugated bilirubin, which does not get excreted out of the body, enters the enterohepatic circulation. So when I mean enterohepatic, the bilirubin, which is now converted back into unconjugated in the gut, goes back into the liver for this process of conjugation again. So that's like a part of the bilirubin gets back and enters the gut and goes back. So that's what is referred to as enterohepatic circulation. So this is basically the mechanism of bilirubin as to how it's produced from heme, how it gets conjugated in the liver, enters the gut. A majority of it gets excreted out, but a part of it enters again the enterohepatic circulation and goes into the process again. So now that we know the bilirubin metabolism well, let's look at what is physiological and what is pathological jaundice in the newborns. So we all know that jaundice basically is excess bilirubin, right? Now, newborn jaundice or neonatal jaundice affects 60 to 80% of neonates, which is a lot. Now, why are newborns at a risk of jaundice as compared to their older counterparts and adults? Okay, we've all had some relative or the other who's had some kid who's had jaundice at birth, might have required phototherapy, might not have required phototherapy. So why is it that these newborns are at a higher risk of jaundice as compared to the other age groups? Number one, RBCs. So there's increased production of bilirubin because number one, they have more RBCs. Okay, so hemoglobin at birth or even fetal hemoglobin is way more than that of adults. Newborn hemoglobin can rate somewhere between 14 to almost 25 grams per deciliter, which is a lot. So because they have more hemoglobin, they have more RBCs, and more RBCs when they undergo hemolysis at the end of their lifespan leads to more production of heme and bilirubin. So that's one reason why newborns are at a higher risk of jaundice because they have higher hemoglobin and more RBCs. Number two, RBCs in newborns have a shorter lifespan. So they can range somewhere between 70 to 90 days. The lifespan is shorter in preterm babies versus a term baby, which is about 90 days. So when you have RBCs having a shorter lifespan, they die faster and produce more bilirubin. So that's one reason why you have more jaundice in the newborns, and this is all physiological. The next step is with respect to conjugation. So we saw in the bilirubin metabolism that once the albumin bilirubin complex enters the liver, it undergoes conjugation by the enzyme UGT1A1. But newborns have immature liver enzymes. It takes them about 6 to 12 weeks for the enzymes in the newborn to be as effective as that of an adult. So because they have immature liver enzymes, the conjugation process is delayed or slow, and that's why you have impaired or less conjugation of bilirubin, and you have higher levels of unconjugated bilirubin. The third mechanism is because of increased uptake or more enterohepatic circulation. So normally the conjugated bilirubin which enters the gut leaves in the form of either stercobilinogen or urobilinogen in the urine and stool. But what happens in newborns is certain mechanisms lead to increased enterohepatic circulation where the conjugated bilirubin is converted back into unconjugated and enters the liver back. We look at mechanisms that exaggerate this enterohepatic circulation, but these three are the main reasons why newborns are at a greater risk of jaundice. So they have more RBCs, shorter lifespan, immature liver enzymes causing decreased conjugation, and increased enterohepatic circulation. Now that we've understood what is physiological jaundice, let's understand why this jaundice is dangerous and what are the causes of pathological jaundice. So, what can go wrong? So, you have excess bilirubin in pathological jaundice either because there's increased production of bilirubin, there's decreased clearance of bilirubin, or there is increased reuptake. Okay, so causes that lead to increased production of bilirubin, number one, and again, the most common cause of newborn jaundice is excess hemolysis. Now, hemolytic jaundice again can be because of various reasons. It can be because of ABO or RH incompatibility, or the presence of hemoglobinopathies like G6PD deficiency, hereditary spherocytosis, and alpha thalassemia. Okay, so these are the commonest causes of newborn jaundice, which is hemolytic jaundice. Second, when there's some kind of birth trauma leading to collection of blood, let's say a cephalhematoma, a subgaleal bleed, if there was a difficult labor or instrumentation like forceps or vacuum used during delivery. So all of this trauma leads to collection of blood, leads to hematomas, and once that blood starts disintegrating, the heme gets broken down into bilirubin, and that's what increases the concentration of unconjugated bilirubin, leading to neonatal hyperbilirubinemia. So that's point number one, where you have increased production of bilirubin. Second, impaired clearance or decreased clearance of bilirubin. So that happens because either there is a genetic mutation in the conjugating enzyme, which is UGT1A1. So you have Crigler-Najjar and Gilbert syndrome, where the conjugating enzyme is deficient or insufficient. And this is one reason why you can have impaired clearance and piling up of bilirubin in the body. Prematurity, like we saw, so preterm newborns have even more immature liver enzyme as compared to a term newborn. So prematurity again causes impaired conjugation because of inadequate and inefficient liver enzymes. And certain medications, hypothyroidism and metabolic causes like galactosemia, tyrosinemia, etc., also lead to impaired clearance, leading to accumulation of bilirubin and neonatal hyperbilirubinemia. The third thing is increased reuptake by the enterohepatic circulation. So there are two types of jaundice that come under this category. That's called the breastfeeding jaundice and the breast milk jaundice. Now remember these two terminologies, they sound pretty similar, but both of them happen because of different causes and happen at different time points. So we'll look at what breast milk and breastfeeding jaundice is in detail later. But just to give you an overview, breastfeeding jaundice happens because of the failure of adequate breastfeeding. So let's say a child is not being able to feed well either because of low milk output, or there's a problem with the latching, or basically there's decreased intake of milk by the newborn that impairs the production of meconium. Now, meconium is a major route of excretion of bilirubin from the body. So less milk, less milk reaching the gut, less production of meconium, less excretion of bilirubin, more accumulation of bilirubin in the body. That's called as breastfeeding jaundice. Breast milk jaundice. So what happens in certain individuals, the breast milk has a higher concentration of the beta glucuronidase enzyme, which causes the deconjugation or conversion of conjugated into unconjugated bilirubin that we saw in the enterohepatic circulation. So those individuals tend to have their conjugated bilirubin converted into indirect, which then re-enters enterohepatic circulation. So these are the two types of uh, jaundice which have similar names like breast milk and breastfeeding jaundice, but they're completely different and they're pretty common. So we'll discuss this later. But just to keep in mind, both of these cause hyperbilirubinemia because of increased enterohepatic circulation. So I hope these concepts are clear. You can have a question on bilirubin metabolism in your theory. You can also have questions asked on bilirubin metabolism in your YY as well. So remember the basics of bilirubin metabolism. What is physiological jaundice? Why do newborns have a higher chance of having jaundice as compared to others? And what are the causes of pathological jaundice? Now, once we've understood this, let's go into history taking. So again, newborn jaundice is a very common case that you will get as a newborn. So usually when you have a newborn case, you will either have a normal newborn or you will have jaundice or probably a preterm baby or an infant of diabetic mother or something like that. But neonatal jaundice again is very commonly given as a case because it is so easily available in your wards. So let's look at how you go ahead with the history taking, which is very important with respect to identifying jaundice and the cause of jaundice. Okay, so name, male child or female child of age. Now, when I say age, it's very important to say age in hours. Now, the reason behind this is that when jaundice develops within the first 24 hours of life, it's always pathological. Whereas if you have, say, jaundice developing on day 3 or day 5 of life, it usually falls into the category of physiological jaundice. So when you have jaundice within 24 hours, it's always going to be pathological. And that is why age has to always be mentioned in hours. So up to 3 days, which is up to 72 hours, if there is onset of jaundice, then always try and mention it in hours. Okay. Birth order, consanguinity. Certain causes of jaundice in newborn are associated with autosomal and recessive and dominant conditions. To give an example, Hereditary spherocytosis, which can cause hyperbilirubinemia in newborns, is an autosomal dominant condition. So that's why your history of consanguinity also comes into picture, because certain hemoglobinopathies like alpha thalassemia, which again can present with jaundice in the newborn period, is an autosomal recessive condition. So that's why history of consanguinity becomes important here. Residence, informant, and reliability. So this is the normal format of taking your history on demographics. So remember, age always in hours, especially up to 72 hours, and consanguinity becomes important here. So once you've done the demographics, chief complaint. So chief complaint, very important, always remember, has to be in the patient's lay language. You cannot say jaundice because that is a medical terminology. So you will say yellowish discoloration of skin or eyes, whatever the mother or the informant tells you, noticed at these many hours of life. Okay, so let's say the child has come to you at 72 hours of life and the mother noticed jaundice 12 hours back. Okay, so that's 60 hours of life. So you will not say yellowish discoloration 12 hours back. Why? This is because it gets extremely confusing for the examiner to sit and calculate that, okay, now the kid is 72 hours. So 12 hours back, that is 60 hours. Don't do that. You always say that the yellowish discoloration was first noticed at these many hours of life. Okay, I hope that's clear. So with the chief complaint, how do you describe it in detail? Okay, so the yellowish discoloration of the eyes and skin was first noticed since, say, 60 hours of life, which was insidious in onset, and the mother will tell you whether the yellowishness has been progressively increasing or is it the same since the time she first noticed. Okay, so that's about the intensity. Now you all know that jaundice usually moves in a craniocaudal direction, so it moves from the head down to the legs. But that is something which is very difficult for the parents to tell you. So usually they will give you a history that the intensity of the yellowishness has increased, but they will not probably tell you a head to toe progression. But it's always good to ask about the intensity, that do you feel that the child appears more yellow as compared to what he did say yesterday? Okay, so that will tell you that the jaundice is progressing, and the rate of progression will also give you an idea of how severe the jaundice is. Okay, so that's how you describe your chief complaint in your HOPI. Now, the next slide is extremely important because it helps you eliminate possible causes of jaundice in your case. Okay, so we saw that jaundice in newborns can be because of a wide variety of causes. So your next set of questions will tell you whether number one, it's conjugated or unconjugated, and number two, if it's unconjugated, which is the most common type of newborn jaundice, what exactly are you dealing with? Okay. So history of etiology, first question is whether there is history of dark urine, pale colored stools, or staining of diaper. Now this, all of these points towards conjugated jaundice. So when you have conjugated jaundice or obstructive jaundice, as we commonly refer to it as, usually conjugated jaundice is because of surgical or obstructive causes. So there could be biliary atresia, there could be choledochal cyst, and these have a different set of presentation and different treatment options available. That's why the first question is to find out whether it's unconjugated or conjugated bilirubin. So when this conjugated jaundice, you have dark urine, pale stools, and staining of diaper because of the yellowish urine. Now, why do you have dark urine and why do you have pale stools in conjugated jaundice? So, what happens once your jaundice gets conjugated in the liver? I mean, once your bilirubin gets conjugated in the liver, normally it will come out through the gut and then in the urine and stool as urobilinogen and stercobilinogen. But when you have an obstruction, let's say in the bile duct, the conjugated bilirubin, which is formed in the liver, is not able to enter the gut because of the obstruction. All of that conjugated bilirubin, which is water soluble now, gets shunted towards being excreted out in the urine. And that's why your urine becomes dark colored because of the excess bilirubin in the urine, whereas the stool remain pale colored because the conjugated bilirubin, which is supposed to be excreted out as stercobilinogen, is not able to come out because of that obstruction. So I hope this concept is clear. This is universal in pediatrics medicine neonatology. So this is just for you all to understand why you have pale colored stools and dark colored urine in conjugated jaundice. Now, having said that, next point is whether there's history of birth trauma, bruising, or instrumentation. Now, all of this point towards kephalhematoma or subgaleal bleed, which can later cause hemolysis and lead to unconjugated jaundice. Question number 3. Whether there's history of vomiting, lethargy, or poor feeding, which is to rule out sepsis, so any kind of GI obstruction like say duodenal atresia, ileal atresia, or metabolic causes like galactosemia. Question number 4. Delayed passage of meconium. So normally a child is supposed to pass meconium within the first 24 hours. But let's say the child did not pass meconium for the first 48 hours and then presents with jaundice. Then you could also think of underlying congenital hypothyroidism, which is again a common cause of newborn jaundice. History of pallor. Now, this is sometimes difficult for the parent to give you history because the pallor might not be very evident to the parents. But if the child has lost a significant amount of blood, let's say he's got an intracerebral or an intraventricular hemorrhage, or there's some kind of concealed bleeding somewhere else, and the child has lost a significant amount of blood, they start appearing whiter. So there's history of pallor. It will tell you that probably there's some kind of ongoing hemolysis or blood loss. Now for intrauterine infections like torch. Now other than jaundice, these kids also have microcephaly, low birth weight, petechiae, and abdominal distension because of hepatosplenomegaly. So if you have a child who's presenting with jaundice and you're suspecting an intrauterine infection, these are another set of questions that you need to ask the mother, that whether he has any skin rash, fatigue, abdominal distension, or the child is low birth weight. History of poor feeding or feeding difficulty, we already discussed this back, but breastfeeding jaundice, when there's inadequate amount of feeding in the first few days of life, there's decreased production of meconium and decreased amount of bilirubin excreted out in the meconium, and this in turn leads to accumulation of unconjugated hyperbilirubinemia. So that's why feeding history becomes very important when you're taking a history of a newborn jaundice case. The family history of jaundice for G6PD deficiency or hereditary spherocytosis. G6PD is X-linked recessive and HS is autosomal dominant disease. The last question is history of jaundice in older siblings. So if there is a significant history, it might lead to the probable causes of jaundice being ABO or RH incompatibility. Now we'll look at what exactly is ABO and what is RH incompatibility, because these are two confusing concepts and a lot of times you are asked questions on this, especially in your viva. So we'll look at this in detail. Just keep in mind that when you're asking for history of jaundice in an older sibling, it's to rule out these conditions. So these are all the set of questions you will ask to find out the etiology or the negative history in this case of newborn jaundice. So this is something that I would like to introduce, that it's called the infant stool color card. This is a very important chart that's often kept in your well baby clinics to ask what the color of stool is. Why is this important? Because when you have pale colored stools, it indicates some kind of biliary obstruction. Most common cause being biliary atresia. Okay, so biliary atresia is when you have atresia or basically inadequate complete production of your bile duct and bile tree, and as a result of which you have conjugated hyperbilirubinemia, because there's no way for the conjugated bilirubin that's formed in the liver to get excreted out of the body. Biliary atresia is one of the commonest causes or the commonest cause of conjugated hyperbilirubinemia, and it needs to be identified early and it needs to undergo surgery within the first 60 days of life to have the best possible outcomes. And that's why this is the card which is often kept in the well baby clinic to ask what the color of stool is. So if you look at abnormal colors 1, 2, and 3, so white, gray, or chalky white are all abnormal colors. Whereas if you have yellowish or maybe greenish yellow colored stools, that's normal. So instead of asking the mother what color of stool it is, which is often difficult to ask, and even the mother might not be able to explain what color it is, it's always good to keep this chart in your well baby clinic and ask the mother to point whether she has any of the baby has any of these abnormal colored stools. This is bilirubinemia, so dark urine. This is the normal urine. So this is what happens in a conjugated hyperbilirubin, where you have pale colored stools and dark colored urine. Now, next question that you will ask will be with respect to complications. So we saw that the most dreadful complication of neonatal jaundice is acute bilirubin encephalopathy. Okay, so when that free bilirubin or the unconjugated bilirubin is able to cross the blood-brain barrier and get accumulated in the brain, it leads to neurological complications. So there's history of inconsolable cry, convulsions, significant lethargy, feeding difficulty, or tone abnormality, whether hypo or hypertonia. All of these are suggestive of possible bilirubin encephalopathy. So you don't really want the jaundice to reach to a stage where it's affecting the CNS, and that's why it's important to identify jaundice, identify the cause of jaundice, and treat it in the right time. So nextly, the next question will be on treatment options. So treatment history. Now this is more important, especially because many a times when you are taking this case of newborn jaundice, let's say in the postnatal ward, the child probably was already diagnosed with jaundice, has already started receiving phototherapy, and then you're taking the case. Or it might be that you're the first encounter and you're the first person who's taking the history, and then you start phototherapy. But usually, as at MBBS level, when we give a newborn case in the exam, the patient has already been diagnosed with newborn jaundice, has already started receiving phototherapy, or probably even finished phototherapy. And that's why your treatment history becomes very important. So, for the above complaints of jaundice, whether the child was admitted to the NICU or to the postnatal ward. Now, definitely, the child is requiring admission to the NICU. It means that the jaundice was probably more severe, requiring more active intervention and more close monitoring. Whereas, let's say if the child has physiological jaundice, which is in the phototherapy range, but the child is otherwise doing well, you can still keep the baby in the postnatal ward by the bedside of the mother, but to make sure that the child is receiving the adequate amount of phototherapy that's recommended. Okay, so the first question is whether the child required admission in the NICU or was he kept in the postnatal ward. Will tell you the severity of jaundice. Second, phototherapy details. Now, when you're asking the mother whether the child received phototherapy or not, there are certain questions that you need to ask to understand whether the mother has given the adequate amount of phototherapy that was advised and whether she's following the instructions or not. So, how many days did the child receive phototherapy, or is for the past how many days the child is still receiving phototherapy if your child is still, requiring PT? So, number of days, hours per day, how many surface? So, number of days is obviously the mother will tell you that let's say for the past 24 hours the child has been kept in phototherapy. Hours per day. So, when you advise phototherapy, it's very important for the mother to understand that the child needs phototherapy as long as he can throughout the day. So the mother is only supposed to take the kid out of the phototherapy to feed, to burp, to put him to sleep, and put him back in the phototherapy surface. A lot of kids. So I'll tell you the clinical implication of this is that a lot of kids don't like phototherapy. It's because you make them naked. They're only dressed in the diaper with that eye patch. It's not comforting to them. A lot of them start feeling cold. So usually kids hate phototherapy. Okay, so a lot of mothers will tell you that every time I put the child in the phototherapy, he starts crying, and then I take him back. Now this is a very common complaint that we usually hear on rounds when we take the postnatal ward rounds. But you need to re-emphasize and explain to the mother that you are doing well. Just ensure that you're feeding the child well, and after every feed, you have to keep the baby in the phototherapy for as long as you can. Okay, so days of phototherapy, how many hours per day, and how many surface. So usually phototherapy can be the single surface, double surface, or triple surface. When I mean single surface, that means light is only from one surface, so either up or down. Double surface, as the name suggests, there are two surfaces. So like for example, in this photograph, there's phototherapy from above and from below. That's called double surface. Triple surface or intensive phototherapy is when the child has really significant hyperbilirubinemia and you want the bilirubin to come down as soon as possible. So triple surface is basically you have three surfaces or three different light sources that's providing phototherapy to the patient. So number of surfaces again interesting to ask. The mother will tell you whether light se upar se hai ya light upar se bhi tha niche se bhi tha. So that'll tell you whether it's single or double surface. And feeding pattern, sorry, during phototherapy. So feeding is very important even when the child is receiving phototherapy because we discussed, when the child is fed well, there's enough production of meconium and there's a route for the bilirubin to be excreted out of the body. So when you're explaining to the mother that that phototherapy is required and phototherapy is the treatment option for your kid who has jaundice, you also need to emphasize along with the phototherapy that feeding is extremely important. It shouldn't happen that the mother is only putting the child in phototherapy but then not feeding, or the mother is only feeding and not putting for phototherapy. Both these combinations will not give you the results that we want. So you have to ensure that the mother has understood the importance of phototherapy, how many hours to keep, but at the same time also ensure feeding in between those uh, sessions of phototherapy. Okay, so that's about your treatment history. Now, in the antenatal history, I'll quickly go over the points that are pertinent and important to a case of newborn jaundice. So, LMP-EDD, what is most important over here is the mother's blood group and the father's blood group. Why? Because again, the most common cause of neonatal hyperbilirubinemia is hemolytic jaundice, and out of that, your ABO and RH incompatibility again are very commonly encountered, and that's why it's very important for you to know number one, what is ABO and what is RH compatibility, and number two, you have to ask for the mother's blood group. If the mother knows the father's blood group, well and good, but you should at least be able to find out the mother's blood group on your history taking. So we look at what ABO and RH incompatibility is in the next few slides. But other than that, your history of TORCH, so whether there's fever, rash, lymphadenopathy. So TORCH leads to, we saw jaundice, and along with jaundice, it can cause low birth weight, splenomegaly, hepatosplenomegaly, petechiae, skin rash, and microcephaly. History of diabetes and hypertension in pregnancy. So why is it important? Now GDM, so when you have infants of diabetic mother, we know that they are big. So you have macrosomia. Macrosomia causes difficult labor. Difficult labor can lead to birth injury, can lead to cephalic hematoma, subcranial bleed, which increases the risk of jaundice. PIH, hypertension in pregnancy, leads to uteroplacental insufficiency, which leads to polycythemia. Okay, so when you have inadequate oxygen or intrauterine hypoxia because of uteroplacental insufficiency, which is very commonly seen in PIH. So hypoxia in the fetus, the immediate response to the hypoxia is increased production of hemoglobin, so you have polycythemia. When you have polycythemia, more RBCs, especially in these smaller kids with polycythemia, with a shorter lifespan of RBC, when these RBCs die, they undergo hemolysis and lead to increased production of bilirubin. So that's why GDM and PIH both increase the risk of newborn jaundice. Now, significant history would be prolonged rupture of membranes, which is rupture for more than 18 hours, with leaking PV, foul smelling like a UTI, all suggestive of polyamnionitis and infection. Now, this can also increase risk of jaundice. Okay, so this is with respect to questions with the first trimester. Now, let's look at what is ABO and what is RH incompatibility. So when I say ABO incompatibility, it is only possible when the mother's blood group is O and the baby's blood group is either A, B, or AB. It is only in this scenario that you can have the possibility of ABO incompatibility. To give you an example, let's say the mother's blood group is B, you will never have ABO incompatibility. So mother has to be O and the baby has to be either A, B, or AB. Now, why does this specific combination of blood group lead to jaundice? Now let's understand what exactly happens in uh, the mother who has blood group O, whereas a baby who has, let's say, blood group A. So when you have blood group A, you have A antigen and you have anti-B antibody. Okay, this is something that we all know. Whereas let's say the mother is blood group O. So when you have blood group O, there is no antigen and you will have both anti-A and anti-B antibody. So let's look at the combination where the mother is blood group O and the baby is blood group A. So here if you see, there is A antigen in the baby and the mother is producing anti-A antibody. So what happens is that this anti-A antibody, which is the IgG type, is able to cross the placenta and go and attack or attach on the A antigen in the baby and lead to hemolysis leading to jaundice. Okay. Just to repeat this again, let's take another combination where the mother is blood group O and baby is blood group B. So the baby has B antigen, the mother has both anti-A and anti-B antibody. Now the IgG type of anti-B antibody in the mother will cross the placenta and will attack on the B antigen in the baby. So when anti-B attacks B, it leads to hemolysis and jaundice. So this is the basic mechanism of ABO incompatibility, where the IgG type of antibodies produced by the mother who has a blood group O is able to cross the placenta and attack the fetus who has blood group of either A, B, or AB. Now let's see, why does this not hold true for other blood group types? Let's say the mother has blood group A. Can that also lead to ABO incompatibility? I just answered this, so the answer is no. Why is that so? Because the antibodies that are produced by an individual who has A, B, or AB blood group are all IgM type. And we know that IgM molecules are very big. They cannot cross the placenta, and as a result of which, you do not have incompatibility with the other blood groups. So remember, take home message from this slide is that ABO incompatibility is only possible if the mother's blood group is O and baby's blood group is either A, B, or AB. That's why if I have to tell you clinical implication of this, every mother who has blood group O, which is again the most common type of blood group, we make it a point to try and collect the cord blood sample to find out the baby's blood group from the cord blood itself, like instead of pricking the newborn, just to see that if the baby has either A, B, or AB kind of blood group, then you need to be more vigilant because they're at a higher risk of jaundice because of ABO incompatibility. I hope this concept is clear. This is probably not something that you will be asked in your exams, but it's very important to understand because this is just pure medicine and it's fun to know things other than just mugging it up. Okay, so now that you've understood this, let's move into the other type of incompatibility, which is RH. So we all know that RH incompatibility affects the second and subsequent pregnancy, doesn't affect the first child. So let's take this scenario when the father is blood group or like say positive, mother is RH negative. Okay, so let's say they have a fetus who's RH positive. The first fetus is RH positive here. So when during the time of delivery, there's some amount of feto-maternal blood transfer that happens during labor and blood loss. Okay, so a small amount of, let's say, the fetal blood enters the maternal circulation. Okay, so the fetus is RH positive, mother is RH negative. So when there is contact of this blood, the mother who's RH negative is sensitized to this antigen from the fetus and starts producing anti-D antibody. But the first newborn is safe because he's already delivered and out. Who gets affected is the second child. Why? So let's say the second baby is also RH positive. Okay, now the mother already has anti-D antibodies that she started producing because of sensitization after the first pregnancy. So that anti-D antibody, which is again the IgG type, goes and attacks the anti-D antigen in the fetus. So the anti-DIgG antibody attaches to the RBC fetus and marks them for destruction. And that will lead to hemolytic jaundice, which will either be mild or severe depending upon the amount of hemolysis. So remember, RH incompatibility only happens when the mother is RH negative and the baby is RH positive. Let's say both mother and child RH negative, then you're not worried about RH incompatibility. And second important point is RH incompatibility doesn't affect the first child, it affects the second and the subsequent pregnancies. So after having said this, which is more severe? Is it ABO or RH incompatibility? So the answer to this question is that definitely RH incompatibility is way more severe than ABO. Why is that so? Why is that RH incompatibility can lead to such severe hypobilirubinemia or such high levels of jaundice that the child might also require exchange transfusion? The reason behind this is that your A and B antigens is present in all tissues of the body. It's not just the RBCs. So when you have antibodies against these two antigens, these antibodies get equally distributed in the body, not just to the RBCs, and they get neutralized in the peripheral tissues. That's why the amount of hemolysis caused in ABO incompatibility is less as compared to RH, because when you have RH antigen is only present on the RBCs. So all the anti-D antibodies or all the RH antibodies that are produced and cross the placenta to reach the baby to attack the RH antigen, all of that are accumulated only on the RBCs, and that is why the amount of hemolysis that can take place is way, way, way more that of an ABO incompatibility. I hope this concept is clear that RH incompatibility is way more severe than ABO. So after birth is, after the antenatal history, we'll go ahead with the birth history. So gestational age, number one, whether it's term or preterm. So jaundice is more common in preterm babies. What is the mode of delivery? So when there's a risk of instrumentation like a forceps or a vacuum delivery, there's increased chance of birth trauma, which again increases risk of jaundice. Birth weight. So if the child is low birth weight, now again, increased risk of jaundice in low birth weight babies, number one is because of polycythemia. So we saw that these kids who are born low birth weight are usually secondary to uteroplacental insufficiency, where there's inadequate amount of nutrition and oxygen reaching the baby in utero. So fetal hypoxia leads to compensatory polycythemia, which in turn increases risk of hemolysis and jaundice. Number two, if you're suspecting a torch infection, so torch infection can also lead to jaundice and low birth weight. So these are the two differentials that you need to keep in mind when you are dealing with a baby who's low birth weight and also has jaundice. Last but not the least, whether the baby cried immediately at birth. So birth asphyxia disrupts the blood-brain barrier, increases chances of the free bilirubin to cross the barrier and affect the brain. And that's why if the child is not cried at birth, again, increased risk of jaundice. Now, neonatal history, very important is your breastfeeding history. So, when was breastfeeding initiated? And following initiation, what the practice has been like. Whether the child is able to feed well, how is the latching, and whether the feeding is adequate or not. So, how do you assess if the feeding history is adequate? We've discussed this in a lot more detail in the normal newborn case, but I'll just quickly go over it. If the child is feeding and able to sleep for about 2 hours after every feed, is passing urine about 6 to 8 times a day, is gaining weight after the first week or five, or not losing significant amount of weight within the first 7 days. That's why, because we know that newborns tend to lose weight in the first few days of life and regain their birth weight by day 7 or day 10. So the child is not losing too much weight or is gaining weight, sleeping adequately, and passing urine about 6 to 8 times a day, that means your feeding is adequate. Okay. So again, your breastfeeding history will give you a clue whether you're dealing with breastfeeding jaundice, because that happens when there's lactation failure. So that's why feeding history becomes very important. Passage of meconium. So like we discussed, if there's delayed passage of meconium, which is more than 24 hours after life, it points towards congenital hypothyroidism, or probable GI obstruction, or exaggerated physiological jaundice. Moving ahead, immunization, this history is very much similar to any other case, nothing specific with respect to newborn jaundice. Okay, so family history. So history of neonatal jaundice in siblings. So that could be because of ABO incompatibility, it could be because of RH incompatibility or breast milk jaundice. Now these are causes which tend to recur in pregnancies because obviously the mother's blood group is going to remain the same. And if the mother has breast milk jaundice, probably because of the production of beta glucuronidase, which leads to unconjugation of the bilirubin, that factor is going to remain constant. So if there is significant history of jaundice in the siblings also requiring some kind of treatment, then these are differentials that you need to keep in mind. History of jaundice, liver disease, cholecystectomy, or gallstones in the family point towards hemolytic jaundice. So either G6PD or hereditary spherocytosis, which is autosomal dominant. Liver disease in the family could be because of Wilson's, Crigler-Najjar, Gilbert, galactosemia, or tyrosinemia. Now, Wilson's is not something that will present as newborn jaundice, but the others and your enzymopathies like Crigler-Najjar, Gilbert, which is because of deficiency of UGT1A1 enzyme, or galactosemia, tyrosinemia, all these are autosomal recessive and they tend to run in the family. That's why it's important to ask for a history of liver disease in the family. Socioeconomic modified Kupuswamy scale, like any other case. So at the end of your history, you will summarize this case as, let's say, a 72-hour-old male child who was born term, weighing 3 kgs at birth, born to a non-consanguineous marriage, by vaginal delivery, who's had a normal transition and breastfeeding, immunized at birth, presented with yellowish discoloration of body since 72 hours of life. The mother's blood group is O positive, baby's blood group is A positive. So this is a case of either physiological or pathological jaundice, most likely due to ABO, RH incompatibility, or other cases. Okay, so this is just like a summary. You need to fill in the blanks depending on what your case is, but I'll just quickly go over what is physiological and what is pathological jaundice, just to complete the discussion on the summary. So physiological jaundice is always seen after 24 hours of life, and it usually peaks about 3 to 5 days and disappears by 2 weeks in a term and 3 weeks in a preterm baby. Whereas if you have jaundice presenting within the first 24 hours of life, it is always pathological. If it persists for longer than more than 2 weeks in a term or more than 3 weeks in a preterm, again you're thinking of pathological jaundice. If there's direct bilirubin, okay, or conjugated bilirubin, that's more than 1 mg per dl, or more than 20% of the total serum bilirubin, if the total serum is more than 5, then it is pathological. So remember, when you have higher levels of direct jaundice, they are always pathological, and you need to find out what the cause is. If the rate of rise of bilirubin is high, if the jaundice is affecting the palms and soles on the Cramer staging, if the bilirubin is more than 95th percentile on the R-specific nomogram, we look at all of this in the part 2, but this is just to complete the discussion of on what is the difference between physiological and pathological jaundice. And last point, if there's associated findings of vomiting, lethargy, tone abnormality, temperature instability, feeding difficulty, lethargy, etc., all of this again points towards pathological jaundice. So just to summarize, in this part, we looked at bilirubin metabolism, what is physiological jaundice, why are newborns at a higher risk of jaundice, what is pathological jaundice, how you take history in a newborn who's presenting with jaundice, and how do you summarize the case. So stay tuned for the part 2, where we're going to go into details about clinical examination, treatment, investigations, and most important, discussion and your Viva questions. So I hope you liked the video. I hope you found this useful. Stay tuned for part 2. Thank you for watching the video. Take care. Bye.